In the past, there have been a range of specific labels used under what is now termed fetal alcohol spectrum disorder, or FASD. In the past, the two most common terms were FAS, fetal alcohol syndrome, or FAE, fetal alcohol effects. Currently, the general term fetal alcohol spectrum disorder is used to cover all the previous variations, with at times the terms alcohol-related neurodevelopmental disorder, ARND, and alcohol-related birth defects, ARBD, being reserved more for children having various profiles related to the effects of prenatal alcohol exposure where the child does not meet the full criteria for FASD. Regardless of the exact terminology used, stress is being placed on the often significant long-term cognitive, behavioral, and adaptive disabilities associated with prenatal alcohol exposure. FASD produces a wide range of cognitive and behavioral impairments. At times, it is challenging to try and separate the actual effects of FASD compared to the complex, traumatic, and unstable early childhood many children with FASD have. While not all women who drink during pregnancy have children with FASD, otherwise whole societies or periods in history would have children all born with FASD, there has in fact been no safe limit found that does not increase the risk of having a child with FASD. As pointed out by medical experts and FASD support groups, this is a 100% preventable disorder. Few other disorders related to intellectual disability are so preventable. However, it is the leading cause of intellectual disability in countries with regular alcohol consumption. The list contained in the notes to this slide of birth defects causing physical and sensory problems give you an idea of the wide and severe range of physical and sensory impairments that can be caused by FASD. This is over and above the cognitive, intellectual, and behavioral problems demonstrated by many individuals with FASD. For the person with FASD who has one or more of these physical or sensory impairments, the medical management for the physical and sensory impairments can be very challenging. This is, of course, particularly true given the often significant cognitive and behavioral concerns exhibited by such individuals. The multiple effects of alcohol consumption during pregnancy, as well as the widespread and severity of such effects, makes a diagnosis of FASD very challenging. Other than confirmed reports of alcohol use during pregnancy, in some jurisdictions only from the birth mother, there is as yet no guaranteed protocol for making a diagnosis. On the other hand, great strides have and are being made to develop highly reliable and standardized assessment protocols. Given all this difficulty in making a diagnosis of FASD, it is still found to be the leading cause of intellectual disability in developed countries. This strongly suggests that, in fact, its rate of causing an intellectual disability or related learning disabilities may potentially be grossly underestimated. The general pattern of global limitations in intellectual and adaptive functioning associated with an intellectual disability get added to significantly when caused by FASD. Individuals with FASD who do not have an intellectual disability often demonstrate significant behavioral and cognitive impairments, particularly around impulse control, problem solving, and attention. As well, they may demonstrate severe problems with adaptive behavior skills. These problems will in general only get compounded should the individual also have a diagnosis of an intellectual disability. FASD is in fact strongly associated with a pattern of cognitive impairments related to a set of capacities called executive function. Many individuals with FASD demonstrate severe impairments in some or all of the cognitive aspects of executive function. These relate to behavioral and emotional regulation, impulse control, ability to manage change, being able to plan and carry through with a plan, keep things organized, and multitasking, even in a limited manner. On top of these difficulties, children and adults with FASD also frequently will have problems with attention. A point that is quite unique to FASD compared to the other disabilities being discussed in this module is that many of the children will also experience significant levels of abuse and/or neglect, particularly in early childhood. From an overall intellectual, cognitive, behavioral, and emotional viewpoint, it can be seen that a person who has an intellectual disability caused by FASD is likely to have a much more severe and oftentimes variable profile of deficits and difficulties than would appear simply by viewing his or her IQ scores. For instance, it is important when assessing the person's adaptive behaviors to distinguish the child or adult's raw capacity to actually do the task or skill compared to whether they actually do them independently as expected in everyday life. It is not hard to envision a person with FASD requiring multiple, possibly lifelong supports, even if they have a diagnosis of only a mild intellectual disability. Of course, all we need to do is add any of the previously mentioned medical concerns into this profile and/or a highly disruptive early upbringing, and such supports become even more likely. From the point of view of intellectual disability, Fragile X has quite a unique role. It is the most common inherited cause of intellectual disability and is caused by excessive repeats of a genetic area on the sex-linked chromosome. There is, however, no correlation between the size of this repeated area and the degree of intellectual impairments in males. Fragile X is also associated with a rather recognizable set of observable physical characteristics. The combination of prominent ears, long face, and low muscle tone is a commonly seen combination. While Fragile X is known to affect males and females, it is typically only males that exhibit the more severe symptoms. This is due to males only having one X chromosome while females have two. This confers a protective capacity for females, as the healthy X chromosome is able to at least partially compensate for the impaired gene on the other chromosome. This is why it is much more common to find females with Fragile X to exhibit more specific learning disabilities or possibly a mild intellectual disability than for males who will generally be more severely affected. Fragile X is also the most common known cause of autism or autistic-like behaviors. Notice that a more severe case of Fragile X will potentially produce a triple diagnosis of Fragile X, autism, and an intellectual disability, again demonstrating the potential for complex diagnostic profiles to arise starting with a single diagnosed cause. It is easy to see when looking at the more cognitively based symptoms, behavioral concerns, delays in language development, social anxiety, short attention span, and possibly hypersensitivity to some stimuli, that there seems to be an obvious overlap between symptoms of Fragile X and autism. Even without a clear diagnosis of autism, children and adults with Fragile X will often demonstrate social and language deficits that will be somewhat like those found in individuals with autism. A pattern of behavioral concerns, short attention span, social and language deficits, increased activity level, and hypersensitivity to some types of stimuli present a range of learning difficulties that can be challenging to work with given how such concerns will tend to interact with each other. Fragile X is also a good example of how specific issues can develop as part of what is called the natural history of the disorder. Fragile X-associated tremor or ataxia syndrome is a late-onset neurodegenerative disorder associated with problems with movement, memory, and the autonomic nervous system. While there may be little or no indication that an individual with Fragile X will develop this tremor or ataxia syndrome, the medical and service systems need to be aware that this may develop for any individual they are supporting. From their 40s onwards, males with Fragile X begin developing progressively more severe problems in performing tasks that require working memory, for instance, remembering one thing while you finish another. Service systems need to be aware and adapt to such changes over the lifespan of individuals with Fragile X. As mentioned earlier, Fragile X is the most common cause of inherited intellectual disability. It accounts for approximately 10% of all males with severe intellectual disabilities and 10% of mild intellectual disabilities overall. Although the level of severity of intellectual disability among boys is equally distributed between mild and severe, the majority of men with Fragile X syndrome have moderate to severe degrees of intellectual disability. Specific cognitive profiles show that they have particular difficulties in sequencing information, with short-term memory deficits manifesting as a weakness in arithmetic and visual spatial skills. In spite of the reported decline in IQ scores with age, adaptive behavior improves with appropriate training. In 1991, the FMR1 gene, the gene specifically related to an intellectual disability was isolated. Thus, we have had accurate knowledge of Fragile X since 1977, with actual specificity of the genetics since 1991. Children and adults with an intellectual disability caused by Fragile X will frequently have a number of autistic-like characteristics, for instance eye gaze avoidance, but may not meet the criteria for autism. Relative to peers with similar levels of intellectual disability, individuals with Fragile X will have more social and language difficulties than may be anticipated just based on knowing the person has a diagnosis of an intellectual disability. Individuals with Fragile X may also have heart problems, strabismus, scoliosis, and seizures. There's also an increased incidence of affective disorders, anxiety, and psychosis. As with Down syndrome and FASD, you can again see that individuals with Fragile X and an intellectual disability will frequently have multiple diagnoses. We have just reviewed autism, brain injury, Down syndrome, FASD, and Fragile X diagnoses that either cause an intellectual disability or are frequently associated with such a disability. Before moving on to discussing other issues, I just want to briefly mention epilepsy and cerebral palsy, two other commonly co-occurring diagnoses. While clearly both diagnoses can occur in anyone, they are disproportionately present for individuals with intellectual disabilities. Many individuals with severe to profound intellectual disabilities will also have CP and/or epilepsy. Approximately 30% of individuals with CP will have an IQ of 50 or less. Between 14 to 24% of children and adults with an intellectual disability will have epilepsy. In fact, it will not be uncommon for an individual with a severe to profound intellectual disability to have both CP and epilepsy. As we have discussed, the addition of further diagnoses clearly presents challenges for the individual and those who are supporting them. Both epilepsy and CP require ongoing medical monitoring and compliance with medication or physical therapies. Staff and parent training concerning these conditions are essential. Both disorders can have obvious impacts on the person's learning and adaptive capacities. Coordination and cooperation across medical, educational, and social services will be an ongoing requirement to assist the child or adult to achieve and maintain his or her optimal functioning. I have been using the terms impairment, disorder, disability, and handicap as interchangeable terms throughout this presentation. However, there's actually a good case to be made that for some discussions, we should use the terms more selectively. The World Health Organization in 1980 used impairment, disorder, and disability to define some critical distinctions. The more formal definitions for each of these three items are: impairment is defined as an abnormality of a structure or function, for instance a slower time to process information or having a limited range of motion. Disorder is defined as the functional consequence of the impairment, for instance the inability to keep up with the typical pace of information flow in class or on the job, or not being able to reach over your head. Disability is the social consequence of a disorder, for instance isolation, loss of a job, or having to make a career change. Picky, 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 you say. Imagine a lawyer and a ballet dancer. Both have heavy objects dropped on their right foot, causing identical breaks in the big toe. While the impairment in toe structure is identical for both, the disorder will differ significantly. The ballet dancer no longer can do certain dance moves. The lawyer may have to alter her golf swing. However, the disability may be even more pronounced. The dancer may need to leave professional dancing altogether and start a new career, while the lawyer may have no disability. Her legal practice continues to develop, while after adapting her golf swing, even her golf score remains the same. By applying the World Health Organization definitions, distinctions are made that apply to how someone functions as a result of an impairment. Not all impairments result in disorders. One may also have a disorder, but not a disability. What these terms and their definitions also do is help us better understand that while the diagnostic assessments used for identifying an intellectual disability may be very accurate, by themselves they do not necessarily represent the level of disability, if any, the person is actually experiencing. Such assessments function much more at the level of determining impairments or disorders than disabilities. This is why for many people who have a mild intellectual disability, it is quite possible that they show little or no disability, particularly in adult life. I am sure it comes as no surprise to anyone that the information required for making the diagnosis of an intellectual disability does not represent who the person is as an individual. We will always need significantly more information about the person in order to make the best decisions regarding how the child or adult is actually doing and what possible supports or service options are needed. Even within the small data set obtained when assessing for an intellectual disability, things can get interesting. At times, for instance, we find that there are noticeable differences between the intellectual and adaptive assessments. This can be particularly challenging for individuals who have one score above 70 and another score below 70, making even the diagnosis of an intellectual disability a real challenge. There may also be noticeable differences within various components of each assessment. There can in fact be so much variation in a person's capacities across different subtests that make up the global score that it is not useful or appropriate to report a global score at all. Such gaps will oftentimes be a sign that further assessment is required to better understand the person. Not explaining the gaps in someone's capacities will make planning for the individual extremely difficult and possibly far off base. The reasons for the gaps will likely be highly informative with regards to various planning decisions. From a service point of view, it will often mean that the actual focus of intervention needs to be on the factors explaining the difference in scores rather than any specific area of concern identified in the original assessment. Examples of factors that might be contributing to the difference between intellectual and adaptive assessment outcomes are cognitive, for instance a memory or sequencing impairment, education, for instance not having been in school for the last 4 years, or having a specific reading or numeracy disability, living in an impoverished and or restricted environment, mental health, for instance an anxiety or depressive disorder, significant behavior challenges such as aggression or self-injurious behavior, executive function issues, a set of higher order skills, for instance problem solving or impulse control. Thus, the assessments needed for making a diagnosis of an intellectual disability, while informative in their own right, will not truly become useful until they are put in the context of a comprehensive and individualized assessment of the child or adult. How well the service system adequately provides the supports and services a person needs in order to assist them in compensating for their capacity limits is a general criteria for evaluating the service system. Knowing the capacity limits of the individual and how these are handicapping the person in their efforts to achieve personally satisfying, observable, and measurable goals, of course, is essential for evaluating a service system. A system that does not have the necessary compensatory capacity, has it in only limited form, or is not capable of delivering services in a timely fashion, is typically viewed as an impaired system. Obviously, no system of service can be all things to all people. A service system must know what it can and what it cannot do, clearly measure what it can do, and communicate openly regarding its strengths and limitations. A system's capacity to support the unique needs of an individual typically varies significantly depending on the complexity of the person's diagnostic profile. For example, individuals with complex diagnostic profiles may easily have 10 to 30 support, caregiver, and professional service providers per year. Providing such supports and services in a timely, coordinated, skilled, and stable form, particularly if such supports and services are needed for an extended period of time, can be challenging. Simply being able to have a smooth and effective communication system between such a large and oftentimes diverse group of service providers can overwhelm the system. Without a solid and effective communication network and case management system, any number of issues can overwhelm the system, impairing its ability to effectively provide services. Families in particular are sensitive to becoming overwhelmed. The frequent formal and or informal demands placed on parents to take on case management duties underscores this issue. When case management requirements are placed on family members who are not comfortable in such a role, oftentimes the system underappreciates the stress this can cause many families. Under this condition, the members strive to adjust and accommodate to the range of needs of the individual while simultaneously attempting to understand and navigate through a constantly changing government and service network. The need for constant advocacy can be very wearing on family members. A system of services for children and adults with an intellectual disability also needs to be aware and sensitive to the mental and physical health of the person's family members. This is one area that is rarely addressed in a systematic manner within an overall service plan for individuals with intellectual disabilities. To sum up, I just wanted to go over a few points. We've discussed what an intellectual disability is. It is defined as an IQ that is approximately 2 or more standard deviations below the norm, around the second percentile, with significant problems in at least one global area of adaptive functioning, all of which starts during the developmental period. When researching the number of people with an intellectual disability, typically it is found that approximately 1 to 2% of the population meet such criteria, but the rate does vary at times to being somewhat higher. Across jurisdictions, a range of different terms are used to designate an intellectual disability. By ensuring you understand the diagnostic criteria, you'll find it easier to know if people from different places or programs are talking about people with an intellectual disability, or a broader or more narrow group of individuals. Common diagnoses of disorders that cause an intellectual disability, or commonly co-occur with an intellectual disability, are autism, brain injury, Down syndrome, fetal alcohol spectrum disorder, and Fragile X. We also briefly touched on epilepsy and cerebral palsy, as these conditions also occur frequently for individuals with intellectual disabilities, particularly for more severely affected individuals. The point was made a number of times that many individuals, particularly those with more severe impairments, will actually have more than one diagnosis. Besides the level of technical training needed to conduct a proper evaluation, making a diagnosis is commonly complicated by the need to rule out other explanations or evaluate results in the presence of other known diagnoses. The information needed to make a diagnosis of an intellectual disability has limited utility by itself. The information is most useful when combined with a comprehensive and individualized evaluation of the person's strengths, challenges, and needs. Ensuring that a detailed, comprehensive, and accurate personal history of the person is essential for effective planning. Most people with an intellectual disability will be assessed as having a mild disability. Such individuals, assuming no other problems, will tend to do reasonably well with little or no supports. People with more severe intellectual disabilities, and those with a mild intellectual disability and a second significant diagnosis, will tend to need ongoing levels of support. For most service providers, particularly service providers for adults, they will find they are often dealing with a higher percentage of people with more severe levels of disability and or multiple diagnoses. Including the diagnoses covered in this presentation, physical disabilities, and mental health diagnoses, it is not uncommon for an individual to have 3 to 5 diagnoses or more. The distinction made by the World Health Organization amongst the terms impairment, disorder, and disability has proven to be very useful for clarifying a number of issues. While the terms may change, the concept they address remain important. Systems of service tend to have a greater difficulty in adequately providing services to individuals with more complex needs. How timely services can be delivered, if sufficient capacity is available, and the quality of services delivered are commonly used to evaluate the sufficiency of the system of service delivery. Expertise in the area of intellectual disabilities is oftentimes limited. Ensuring a system-wide effective communication system as well as adequate case management capacity is essential. This presentation hopefully has given you a broad overview of some of the key issues regarding intellectual disability. By gaining a better understanding of what an intellectual disability is, relative to a range of related diagnoses, you can better understand how it stands alone as a diagnosis in its own right. Certainly for service providers, it will be a fairly common occurrence to see individuals who have a diagnosis of an intellectual disability, as well as 1 or more diagnoses. By increasing your knowledge in this area, you'll be able to be more effective in providing services and supporting the overall system of services available for children and adults with a diagnosis of an intellectual disability.